Good afternoon, Raul and Thanh. Thank you for the possibility to talk with you both. Congratulations in third place for this great paper. It's called The Global Impact of the COVID-19 Pandemic on Stroke Hospitalization and Mechanical Thrombectomy, that has been recently approved and put online. So thank you very much for being here. I'm going to ask you several questions about this paper and the results. So let's start with the first question. This is was a huge collaboration study with so many centers. How many centers were involved in that?
Well, first of all, thank you, Rodrigo, and the LINNC organization. For us, it's a tremendous honor to have this opportunity to share our finds with the LINNC community. So on behalf of Thanh, myself, but the many collaborators in this project, this is paper one out of a series of 3 papers looking at the global impact of COVID-19 in stroke care. We look in this particular paper on the impact of COVID-19 on mechanical thrombectomy, so specifically comprehensive stroke centers. And we have a second paper that has looked at the impact more of hemorrhagic disease, specifically subarachnoid hemorrhage and aneurysm care. And a third paper that actually look at intravenous thrombolysis. And in that paper, we actually look at not only comprehensive, but also primary stroke centers. So it's actually an even broader survey of what happened during the pandemic time in terms of stroke care. But this one was specifically dedicated to comprehensive centers, mechanical thrombectomy. We had a total of 187 centers spread across 40 countries, over 6 continents. So you could really get a broad view of what was happening in a global perspective. We also want to get places that were the epicenter of the disease, like New York and Barcelona, France very well represented, but also places that at the time of the survey weren't as affected, like Greece and some other countries that didn't have the same degree of problem, to try to understand the impact of the social and behavior changes in relation to the pandemic versus the burden imposed by the infection itself in these different hospitals. And the findings, as you probably could notice, were fascinating, right? We could see across all these different places that the pandemic affect more the places where COVID-19 infection was a bigger problem, but that was distributed across all types of stroke volume and COVID infection volume hospital representation.
So for sure you have this it's very well represented, this sample that you have. It represents all continents and really, as you said, all different realities around the globe. So it's a big, high volume COVID, low volume COVID, and that's interesting of the paper. Thanh, why do you think there were so many difference or some difference that in between the hospitalization rate for stroke in between continents or between places?
It probably reflects on the tempo of spread of the COVID-19 virus across various continents. So for example, as you know, it started in China, and then Europe became a hotspot, and then it came to North America. So when we look at the data, we notice that the dips in the stroke hospitalizations and the mechanical thrombectomy reflected where the COVID-19 started earliest. So for example, in February in China, we saw big dips in volumes of stroke hospitalization and mechanical thrombectomy. And then in the early March, we saw these dips in Europe. For example, Spain had profound declines at this time. And then later on in North America, last week of March, early week of April, that's where we saw the dips in North America, the most profound. And these dips corresponded with where the peaks of COVID-19 were highest, as Raul just mentioned.
So in the data that you obtained, you have a 19.2% of decrease in the stroke in general, and mechanical thrombectomy were 12.7%. That's a huge number of difference. So So you also have difference between, although you have less mild stroke coming into the hospital, but you didn't have difference between the ratio of stroke and mechanical thrombectomy that one can think could have been happen within this difference. So several. What do you think about that?
So that's a very important notion to discuss. So when you look at these changes in volume, it's important to understand the absolute volumes versus the relative volumes, right? So as you said, the absolute volumes of any stroke hospitalization decreased by 19.2% globally, and the absolute volume for mechanical thrombectomy by about 13%, 12.7% to be precise. So both dropped, okay? But the change in stroke volume in hospitalization was higher, right? It's like a 19 to 13% difference. So when you look at the ratio, you actually don't have a drop in the relative number of thrombectomies that were happening per center. This actually happened also in other papers. They showed this happen in relation to mechanical thrombectomy and thrombolysis. Some papers have actually reported an increase, meaning, yes, I'm doing less thrombolysis and I'm doing less thrombectomy, but in relation to the number of patients that are admitting, I'm actually doing more of these acute reperfusion therapies. And the most plausible explanation is what many other papers have already discussed, which is you start to admit the less severe strokes and the TIAs. So you all have a over-representation of the more severe strokes and large vessel occlusion strokes, which are more suitable for thrombectomy procedures and intravenous thrombolysis. And that's why you have this discrepancy where relatively the acute reperfusion therapy sometimes even increases proportionally, right? But it's important that we understand that absolutely the number of LVOs and the number of treatment for LVOs and intravenous thrombolysis has decreased across the board.
I was amazed with the numbers. When you read the paper, you read that more than 20,000 strokes coming in, or so many mechanical thrombectomies around the world. It's a huge number between the months. 3 months period is so many centers doing a lot of cases around the world, although it was a COVID-19 pandemic state. So that's fantastic. So the SARS-CoV-2 infection has been shown to have a prothrombotic state or effect in the body. So how do you explain that although it has a prothrombotic effect, we saw less strokes or less mechanical thrombectomies in global?
There's several hypotheses for these, and of many papers that have been published, the most commonly cited is fear. Fear of patients contracting the coronavirus is probably the most common reason for patients perhaps not presenting to the hospital or to the ERs because they don't want to have a nosocomial or hospital-acquired infection. Other hypotheses include that with the lockdowns, with protective measures of wearing masks, people may have less exposure to other viruses like influenza, for example, which might also trigger a prothrombotic state. So overall reduction in exposure to these viruses may also account for why there's an overall decrease in stroke admissions and stroke hospitalizations. And one of our authors in Australia commented on the cancellation of elective surgeries being a potential correlate. We have less perioperative strokes. For example, when patients go off anticoagulation, they're more vulnerable to having stroke. So maybe we're seeing less perioperative stroke in that regard. And then finally, it's not inconceivable that there's a true decline in strokes. And this was reflected in one of the papers from the cardiology AHA. Alice Jacobs wrote about people in a lockdown situation having better behaviors where they're potentially more compliant with their medicines. Perhaps they're eating healthier diets, taking care of their blood pressure. And so these behaviors may also have a true decline, which is not necessarily a terrible thing. I'd be interested to hear Dr. Nogueira if he thinks, do you think we have a true decline, Dr. Nogueira?
Yeah, that's really a question that it's very hard to to address, right? So one of the things that we all expected in the very early phases, we were all expecting a surge in strokes, right? Because the prothrombotic state, we then had the reports from our colleagues from Mount Sinai about strokes in young patients without vascular risk factors related to this COVID, prothrombotic syndrome, like what you have in the lung, you also have in many other organs, vascular systems, right? Including the heart and the brain. But I think those cases, they actually exist, but they are relatively rare. What more commonly you see is the overlap of two common diseases. Stroke is common, COVID is common, and I think most of these cases are association rather than a causation per se. And I think that's why we didn't see an increase in the number of strokes. The reasons why we saw a decrease in the number of strokes is it's really fascinating to me, because I understand why a TIA or minor stroke would stay at home. But I don't understand why someone with a severe LVO stroke would stay at home. I don't think it's plausible that these people just, oh, I'm gonna see what's gonna happen, right? Same thing for MI, acute MI saw a big drop, right? And the same thing even for brain aneurysms. These are very severe conditions with dramatic presentations. So you really have a hard time believing that people will just disregard them out of fear to go to the hospital. So I do think that we have to be open to this hypothesis that Thanh mentioned, that maybe these behavior changes had a positive impact somehow. The other thing that supports this hypothesis is the fact that even in countries like Greece, that at this point in time, when you did the survey, had very little COVID-19, they had decreases in the incidence of stroke and treatment for stroke. So suggestion that this was more potentially like related to external factors rather than just the COVID infection. But I think that's one of the big unknowns in the field right now, is what is the actual root cause of this decline?
Yeah, that for sure. That's still a question that hasn't been answered, and we still probably need more data about that. So we also haven't seen more. It's not in the paper, but have you seen more mortality of about stroke outside the hospital? Or
so I think the data about mortality, we didn't have hospital mortality data analyzed in this paper, as you can imagine, coordinating out this work across 6 continents was very hard. You had to be very thoughtful about the information we would expect from our colleagues. But we do have another analysis that you did in United States only, where we actually demonstrate that there was a significant increase in hospital mortality during the pandemic in relation to stroke. And the reasons for that are still unknown. I don't think it's necessarily because we had COVID-19 strokes, right? Because those are a small percentage of our strokes. I think it's really compromise in the care, but that showed an important, it was actually 40% increase in hospital mortality in United States hospitals in the admissions for acute ischemic stroke. So it is something that we have to dig further into and try to understand what was the root cause. Probably was a decline in the quality of care.
So this second wave that is coming, that we're living now, do you think the first wave prepare us for now for having more experience about the management of these cases, or Or do you have the feeling that this is not as a huge a decrease between the second wave and the first wave in the incidence of stroke?
Yeah, we looked at a little bit at this with the third paper that Raul mentioned, looking at stroke care and intravenous thrombolysis, which is pending. So in this paper, I mean, without revealing too much, we're seeing some recovery. And so we think that because of the preparations, all our societies have done and we've written about, we think that with these preparations and with stroke education, public outreach, that more patients are presenting to the hospital. And so we're seeing less of these declines because of public education.
So also you were expecting when you compare the groups and because you compare the 3 months and the 3 previous months, and then you compare it with 1 year previously, and you were expecting that there was also a natural increase in the number of the mechanical thrombectomy done because of experience and more diffusion of the technique. That was okay. That was those were your results also.
Raul, why don't you take that one?
Yeah, I think, Rodrigo, that only reinforces, right, that this is a real problem, because we would naturally expect an increase rather than a decrease. So when you compare the same period across the 2 different years, right, and you are seeing a decrease when you would expect an increase, it only reinforces that this is a real phenomenon. And I think we happy and grateful to all the collaborators to have really put what we believe is the largest of this type of analysis. It is really congruent with all the other analyses that were done either at a single center or regional level or country level, but now again in a global perspective, and it shows the different impacts. That is the impact of the COVID-19 infection burden in the hospital, but it goes beyond that. Even hospitals that had a low COVID-19 hospitalization, they still suffer this. They still had a significant impact. So whether it's related to social behavior or perhaps better health, which is we talk about the good things, right? People are maybe sleeping better, not going to bars and spending nights out and all that. But at the same time, we know there is a lot of mental disease and depression and potentially more use of drugs and alcohol, right, during the pandemic as well. So it is a fascinating entity that I think we are not going to have a full understanding for the next a couple of years. It's really, we're going to need more data to understand what is the root cause for this decline, right? I think for now you can only say this was a significant and real decline, and you can hypothesize what are the potential reasons for this decline, but we can't really pinpoint just yet, because for any argument in one direction, there is a counter argument in a different direction, right? So it's very challenging.
One potential factor that we are very happy to have found from the study is that, as Raul mentioned, in areas where COVID-19 was not endemic, we still saw these declines, which suggests that access to hospitals who have high COVID-19 burden is not the reason for the declines. People who have good access, even where areas where they didn't have a big COVID-19 burden in these places, we still saw these declines. So it's not because of inability to access a hospital because we're too many COVID-19 patients, for example.
And did you see some data about the lockdown? If there were lockdown in places where more lockdown or less consult, for example?
We adjusted our analysis based on when we saw the peaks of COVID-19 by the geographies, by country. And even when we did this adjustment for this analysis, we still saw the declines, commensurate with each geography where there was a lockdown. So we didn't look at the lockdown date per se, but we looked at where the peak of COVID-19 was highest in each country in our paper.
When you put the purposes of the study in the paper, you spec a lot of this result that what you will finally have, but which were the most surprising result that you encountered, you find with your results in this study?
It comes with the subarachnoid paper. That's a big surprise there. So I'm going to save that until that paper's out. What do you think, Raul?
Yeah, I think I think we had some pre-specified hypotheses prior to the analysis. I think you could conform most of what you expected. There were some fascinating aspects. For instance, things that I really think you have to think about and highlight, okay? One of the things you look was the proportion of patients with COVID-19 that come to the hospital with COVID-19 and have the diagnosis of stroke. And that number, when you look at globally, it's just 1.5%, right? So yes, you can have this overlap, but if you come with COVID-19, only 1.5% of the patients will have a stroke. When you look at the other way, okay, what's the proportion of stroke patients that will have COVID-19? It's a little higher, it's about 3.3%. But the point here is it doesn't matter how you look in how they overlap, right? AB or BA, the numbers are very small. So this overlap, it is not the cause of the significant drop that you have had in the amount of stroke care you are providing, right? It's probably a lot more than the viral infection itself. And it only reinforces this concept of collateral damage, right? There is a lot more happening than just people get infected with COVID-19. Behavior changes, system of cares are getting affected by what's happening. And I think that's probably the most important message of the paper is this discrepancy between how frequent the overlap is between these two conditions versus what is happening to stroke care at a bigger level. And it is okay, the cases with COVID-19 and stroke, when you have overlap, specifically when there is a causation, they are very challenging cases. And you have to accept bad outcomes in that setting, but it's not okay to accept collateral damage from the pandemic on stroke care. These should be things that you should be able to overcome. I think that's for me, was one of the most educational points about the paper.
I'd like to add something that we were surprised is the degree of stroke care available in areas in Africa, for example, where there's just mechanical thrombectomy is non-existent in many countries. And when we went on to look at intravenous thrombolysis, we were trying to get data on intravenous thrombolysis, and we were really focusing on Africa because we wanted to find out what's going on here. And many countries in Africa do not even have intravenous thrombolysis available. So this was a surprise for us, at least for me, because we would have thought a drug that was approved 25 years ago, by NINDS standards, is still not available in a good part of the world as it is today. So that was a surprise for me.
So how do you foresee the coming future with the vaccine? And do you see that we're gonna raise our numbers soon? We're gonna begin raising the numbers of mechanical thrombectomy and stroke coming in, or we just change the health status of the people working at home, maybe more with not so many stress, or not?
I think our hope is that things will slowly go back to where you were before. It's gonna take time. I don't know about you, but every time that you have a surge, we we have some impact on our center, both at a level of elective volumes, that's very clear. But even in terms of stroke care, because the hospital gets overwhelmed. Right now, I think the second peak here in the state of Georgia is probably worse than the first peak. And not uncommonly, you have to go on diversion. You have no beds to take new stroke patients. And we just have to hope that our other colleagues in the other stroke centers can care for those patients. And that's part of the chaos that happens during the pandemic. So I think with vaccination and better control of the disease, the volumes of care will go up to where they were before, hopefully. It would be good to think that some of the good behaviors that we would adopt during the pandemic, if that was indeed the case, right, would persist, but that's not really consistent with what you best know about human nature, right? We tend to go back to wherever we were before very easily after the stressor disappear.
Yeah, here in Boston, we're in the second wave, and we're noticing that we're better capable of adapting because of better preparation from the first wave, such that we're not on divert as long as we were during the first wave. So that's a very positive sign. And also the communication between hospitals, at least in our area, has been improved, whereby we're thinking about redistribution of patients just so that one hospital is not heavily hit as opposed to the other hospitals with COVID-19, so that the distribution of care is evenly spread through the region. So these kinds of preparations are important for any potential surge, any pandemic, hopefully none more. But I think these preparations will be key in helping us preserve access to stroke care.
Well, yeah, we hope as you said, humans will tend to go again on the same route. So, well, we'll still have a lot to work and a lot to do and increase our treatments, and to care for the patient. So, dear Thanh, dear Raul, thank you very much for your time. It was a great pleasure to have this conversation with you both. Thank you for your time. Thank you for being here in LINNC Online. So you're welcome to see you again. Hope to see you again very soon.
Thank you, Rodrigo, very much for hosting us. It's a great pleasure and honor. And thank you for your contributions as well to our field.
Thank you, Rodrigo. Thank you to everyone in the LINNC organization. It's been a pleasure. Hope to see you again soon.
Thank you. Thank you both.